Okay, well, thanks for inviting me, Chevy, to give a little update on what I've changed in my practice. And it's interesting, as I was thinking about this, it's not really one thing that's changed in this past year, and that's none of us. A lot of things have changed over the years, and sometimes in steps. Maybe it's robotics or a transition like Todd talks about, where suddenly you're really shifting and trying a new procedure. And I thought, it's actually probably 10 small things that end up being one thing, but what's changed is a way of thinking about surgery. And maybe COVID let that happen, and maybe sort of a transition in my practice and a number of things. But I think what really shifted for me here in my disclosures is rethinking more complex procedures. And some of it, I have to say, is egged on by the good collaboration we have where we discuss cases and some of the banter around minimally invasive and robotics and navigation and saying, well, are we pushing ourselves as hard in complex spine as the guys are doing when it comes to MIS? And so here's a case I did with my mentor, JP Farsi, a number of years ago. And it was considered at that point, pretty standard, pretty routine that if you had a complex case, that patient would lose a bunch of blood and they'd be in the ICU for a couple of days and they'd be in the hospital for 10 days, 2 weeks. That was kind of the standard. And then here's a case that I did with one of our fellows just a few weeks ago. And now the standard is you don't lose 4 liters, you use 500 cc's. You don't operate for 8 hours, you do this in 4 hours. You get the patient out of bed the next day. And this patient stayed because of COVID and didn't want to go to rehab, and her wound was oozing a little bit and she didn't want to go home with a drain, but could have gone home on the 5th day. So half the time, less than half the blood, half the OR time, half the hospitalization. So what changed, right? And what changed is really everything. And it's a whole bunch of little things that have really changed this. And what's changed in me, when the question is, well, what have you done differently in this past year or this past couple of years? And I think it is really focusing on recovery kinetics and learning the impact of complex surgery. And it's interesting, when Shiraz came over and said, look, my T-lifts are going home in a day or two, and the standard was maybe 3-4 days at HSS. I said, well, let me start telling my patients they're going home the next day. And you know what? Amazing. Once you start thinking that way, half my patients could go home in a day and the other half went home on the second day. And I could get patients home in 2 days. And in fact, the numbers were very similar to what we're doing with MIS. So I realized it required a change in how we think about our procedures, about our patients, and about their recovery. But because multi-level surgery has more pieces, more steps, more complexity, perhaps, it required rethinking a lot of the individual steps to an amalgam, say, I'm going to make one big change. And that big change is to think of our complex surgery as manufacturing something complicated. So here's a Toyota production system, right? So it's a bit of a cliche now, but it's an interesting exercise where you start to say, my goal is to manufacture a successful complex surgery and get a patient reliably to a better state and consistently improve to reduce cost and reduce waste. And once you tell yourself that's how I'm going to think about my surgery, not me, the surgeon, executing a plan, but me, the surgeon, taking responsibility for the whole production process, then you start to think about a lot of the other parts that are impactful in that goal. So manufacturing a successful patient outcome and consistently reducing cost and waste. And so then when you think about alignment, you recognize it needs to be personalized. And then when you realize I'm going to realign, you start to recognize there's a difference where I realign. And so it seems like an academic nuance, and yet it's rather dramatic in its impact when you add this to the 10 other things that you change once you think of a customized, reliable production on a patient. So yes, I do believe that imaging and navigation are essential for better outcomes, but not all the time. So in a complex patient with tiny pedicles, no anatomy, absolutely. For the routine open T10 to pelvis, I don't think so. It's going to add more time. It's going to add more cost. So I won't use it for those cases. Some of the other things that I've added, again, as part of that overall big change, is rethinking each step. How can I do an osteotomy a little faster, a little safer? So we use this little outrigger with a sliding telescoping rod, control the osteotomy, boom, convert it to a 4-rod technique, lots of data around it. Small change, but the goal was to figure out how each little piece can incrementally add to one big change in the outcome, and then tethers for PJK prevention. Big part was change in blood management. It used to be okay to lose a lot of blood because we just give more blood. What's the big deal? And when you start to recognize each little thing makes a difference, and that transfusion has a big impact on recovery kinetics and complications, you really think about not losing blood. So lots of Aquamantis, changes in blood pressure, working with the anesthesia team, TXA, IV, topical, all that stuff. And here is probably the biggest change that's happened since I've been at HSS, and I would say the last probably 2 years. And Shiv, you've been part of that, and actually we've all been part of that, this focus on the perioperative anesthetic management of our patients. So the early recovery after surgery, the ERAS pathways, and on the pre-op part is the optimizing the patient for the ERAS pathway. And then I'm a big believer in these ESP blocks. So I've had some T10 to pelvis patients that stop their PCA the next morning and say, you know what, I can't believe I had surgery. I really don't have that much pain. And they take 4 pills a day, and they are like post-op day 3 saying, when can I go home? So it doesn't work every time, so we're working on that. But when it works, it's absolutely remarkable. And so I think that as part of that shift in my mindset of taking responsibility for the entire production process and looking ahead, I think it'll be interesting as we go upstream and downstream to contribute to those areas, because of course big cost drivers are not just the OR that we can control in terms of biologics, implants, OR time technologies, but it's readmissions and reops that really drive the cost and the durability of our procedures. And I think we're really working hard on that part. And probably in a year or two, we'll be able to report back that we've also shifted the curve dramatically on that. And the pressures are these, just to conclude, is demographic shifts are inevitable, the cost drivers are inevitable, but this is a really neat piece of data. When you look at the predicted shortage of orthopedic surgeons, and I bet for spine surgeons, it's probably as a percentage an important part of this. With an aging population, we're not making more surgeons, and the demand is going up dramatically. The number of patients in their upper 70s, 80s that are demanding spine surgery, and unless we can do these faster and more reliably at a predictable cost, we're going to get into big trouble. So I think lots of things are still going to come that are going to make us more precise. But I think it starts with that mental shift. And for me, that was an important one, really starting to take more ownership of the production process and saying, yeah, I think I got really good as a surgeon, or yeah, that technology is really cool, or oh, I really like that, and say, hold on, how do all these pieces fit together? If I were the manager of a plant and I had to make more cars or more computers and they had to, be 99.9% reliable, why aren't we doing that in regards to our spine patients? So that's all I had to offer, but I think the future is really instigated by our collaboration and by seeing what we're learning from Shiraz and others and recognizing technology is great. The competitive spirit is great, but our ownership of the whole process is important. And I think, why not think of a T10 to pelvis that goes home routinely in 2 to 3 days and costs less than $50,000 for quality adjusted life year? That's the goal. And that means we need to take ownership of all parts. So that's been a big shift for me. Thank you.
Thanks, Frank. I think important, when we think about these things, often we get involved in the technical side, but as you point out, it's sort of have a holistic global picture of this stuff and all the little changes around it is extremely important. So next.
With the technology is amazing and it's fun and we as surgeons love that stuff. But then put it back into question for this patient or this procedure or for this expected outcome. Do I really need it? How much value will it bring? Is it a cheaper, better alternative? I don't know. It's perhaps less an issue for MIS, where you're very dependent on technology because you don't have surface anatomy. So I recognize you obviously need a lot of technology, but there are all the other parts that are highly relevant.